Okay, so here we are again. Welcome to episode 6 of the eyecare.education podcast. And we've got a very special guest this week. We have Elaine Styles from Vision Care for Homeless People. So good afternoon to you, Elaine.
Good afternoon. How are you?
I'm very well, thank you. How are you?
Yeah, very good, thank you. Yeah.
Good. Excellent. So I suppose first of all, I'll let Elaine introduce herself and tell us a little bit about her background, how you got into optics and how you got to where you are today with Vision Care for Homeless People.
So my name's Elaine Styles. I'm an optometrist and I've been qualified since '93, I think. I currently spend my time sort of 3 different things. I do part-time in the contact lens department at Moorfields. I also work in high street practice, and then I'm the chair of Vision Care for Homeless People. So I originally got into working with homeless people. It was back in '97. I saw a small advert in an optical journal looking for sort of volunteers for the Crisis Christmas. So I answered the advert and went along, did a couple of shifts, and basically I was hooked. I mean, you met some sort of really sort of interesting people, and it was just really enjoyable. So the next year I sort of dragged a few friends along, and then sort of the following year I ended up sort of taking over sort of the organisation of the service. So up until I started volunteering, it was run by an optometrist who just ran it as part of his domiciliary service. Right. So the difficulty we had is that he was only sort of seeing people who were actually eligible for sort of the normal GOS services. And basically sort of that didn't sort of quite fit with the way that Crisis wanted to be all-inclusive. So when sort of I took over the services, we ended up changing it that we would see absolutely anybody who wanted or needed an eye examination. So we just expanded the service out to whoever sort of had that need.
Okay.
So
yeah. So is that when it became a registered charity under the current
No, basically that was just in the very starting. We carried on doing just the Christmas up until sort of 2002 was the last year we did just Christmas. And then I was approached by another optometrist, Harinder Paul, who was interested in setting up something throughout the year. And then with 2 others, so 4 optometrists, we got together and started Vision Care for Homeless People. So what we did from there is that we would sort of 1 week through the month each, we would all sort of test in the Crisis Skylight Centre near Liverpool Street, and on a rota going through. We ran that for a few years as a not-for-profit company because we approached Charity Commission, who said they wanted to see whether there was a need for it, and there obviously was. So then in 2007 we got charity status, so we basically went through the application process, and then from there we just sort of gently started expanding the service.
Okay. So how many clinics do you have now? Nationwide?
Currently we have 8. So we have 3 in London, and then we've got Brighton, Birmingham, Manchester, Exeter and Leeds. And we see sort of probably about sort of, I think it's about 1,800 people a year at the moment.
Wow.
Well, up until sort of March time, we were sort of how we had all those clinics busy. And we also have another sort of another clinic in the pipeline, which is in Stratford in East London, and we're also investigating other sort of locations as well.
Okay, so how does it work with regards to setting up a new location? Is it almost like an optom will take control of an area and almost take on the brand, for want of a better word?
Yeah, I mean, generally the clinics we've had so far is actually what we look to do is sort of looking for a team of people. We have in the past tried to set it up where sort of one particular person is sort of interested in sort of running a clinic. But we found that, I mean, people's circumstances change and things like that. So what we need is actually a team. So one of the newest ones we set up a couple of years ago was a clinic in Leeds, and we have a really amazing team there that actually sort of run the clinic basically between them. So that's a mixture of optometrists, dispensers, clinical assistants, and also we have lay people that get involved as well who help with administration, fundraising, fundraising and things like that. So I think the core of it is actually finding the team that are interested in actually running that clinic. Then going from there, when we've got the team together, we look at the homeless centres around who potentially are interested and also that have space and time for us to fit in with their timetable, because often the homeless centres have actually got quite a busy rota of other services coming in. So we particularly like it when we can be part of a holistic approach for sort of general healthcare. So in most of the centres we have, we also link in with sort of like medical, podiatry, sort of nursing services, mental health, things like that. So we can inter-refer between us.
Yeah, definitely. So all the clinics are run currently through existing homeless shelters and homeless charities in that sense. So you've got that support group within there as well for you.
Yeah,
excellent. So how does it actually work for the homeless person then who wants to come along and have an eye test? What's the actual process for them?
So basically for them, they just need to walk in and use our services. So I was saying all our clinics currently are within sort of like homeless organisations. So it's a mixture of things like Crisis, St Mungo's, West London Mission, George's Crypt Leeds, sort of Cypher Fireside in Birmingham. So they're all actually within homeless centres, and the majority of those are actually day centres. So with a day centre, someone can be coming in to access services. So it might be that they're coming in to sort of get a meal, to have a shower, do some laundry, access mental health support services, sort of financial advice with sort of benefits, accommodation, things like that. So they're already coming into those services. So what we try and do is to tap into that and sort of make it part of their rehabilitation in a way, just sort of like getting another sort of thing. So basically getting their eyes tested and replacing or sort of giving them new glasses so that they can actually see what they're doing, apply for accommodation and applications for forms and things like that. Because probably about sort of 40% of the people we see just simply need something like a pair of reading glasses. So because they can't read sort of application forms and things like that.
Yeah, definitely. I mean, it's one of those things you see a lot of support for homeless people in terms of wanting to encourage them back into society and into applications for various things, but it's often overlooked that they actually need, there could be a refractive error, they could just need a pair of reading glasses to be able to go ahead and do that. And again, if they want to get into work and all that kind of stuff and become rehabilitated, you do need to be able to see, don't you? So it's an important service in that sense. So how does it work in terms of funding for the actual patient? Because as you mentioned before, when it was originally started, it was mainly seeing people who were eligible under the GOS system. So how does that work nowadays? Is it still a similar criteria? Can you still claim NHS contribution, or is it all free at the point of service?
So basically, yes, definitely free at the point of service for anyone that comes to use our services. What we do is the same as an optical practice. We will register with the local area team. So basically, we go through all the normal sort of application for basically a mandatory service contract as a practice would do. So we have to go through all those sort of normal sort of systems and things like that. So the whole process of application. And anyone that comes to us who is eligible for GOS services, we can then claim that that voucher back. So we probably find that the percentage, unfortunately, over time has reduced. I think very much originally when we sort of started off and there was just literally the four of us running sort of once a week, probably about 50-60% of the people we were seeing were eligible for GOS services. So when it was purely a volunteer-led organisation with no other expenses other than dispensing, administration and things like that, it was actually self-funding. But then as we've gradually increased the number of clinics that we have, unfortunately we now need to look for sort of external sort of funding sources. So probably currently I think it's only about sort of 15-20% I think of the people we see, and some centres do vary. So for example, at Crisis Skylight, we tend to be working with people who are sort of getting that next rung up on the ladder. So they possibly have already got into accommodation and they are now looking for sort of work, or they're doing training courses and things like that. So they're probably, or majority of those, we tend to find probably about 60% of those might be on benefits. Whereas when we go to some of the other centres, we're working with people who are literally just sort of coming in off the street, and there we may only find that about 10% of people of those are eligible for benefits, and that might be sort of people who are over 60 or diabetic or family history of glaucoma, things like that, because they haven't actually got through that sort of administration hoop of actually getting themselves registered for benefits yet, because they are literally just coming in off the street. So it varies greatly, but if they are eligible, we claim the vouchers and that goes towards funding. If they aren't eligible for NHS, we do exactly the same service, full eye examination, spectacle dispensing, and then we provide that. So basically it's like having a private eye examination funded by the charity.
Yeah, yeah. I think whenever we've run CET workshops based on vision care for homeless people, and I think there's quite a big misconception about NHS claims and people who are homeless being eligible for NHS help. And the biggest reason is obviously not having an address. And a lot of people feel that if there's no personal address for the patient, then they wouldn't be eligible. So how do you get around that kind of situation?
So basically having being homeless doesn't actually exclude someone from claiming benefits or from claiming GOS. I mean, say for example, if they were over 60 or diabetic, then you can automatically sort of use the normal sort of GOS. Equally, someone could be homeless and still be on something like ESA or sort of other benefits. So what we would normally do is if they do have a temporary address, you can give that, or if they don't, you can give a care of address, and that might be a day centre or a hostel or something like that, or basically just a sort of like the benefits agency, maybe where they actually claim the benefits from. So you can put a care of address, so someone can still be no fixed abode and eligible for GOS services.
Yeah, and with the diabetic one, did you need a GP address on that, or is there any way around that?
All our clinics are set up that if someone doesn't have their own GP, that we do have a local GP service who will help them out if they're not registered. So what we do is in each of our clinics we set up that we have GP, emergency services, and all the local sort of paths through, so we can actually manage the care of that person. So say for example at the Crisis Skylight one, there's an organisation called Health E1, which is basically in Brick Lane, and they're a homeless GP service. So what they will do is that anybody who isn't registered, they will see them drop in the morning or by appointment in the afternoon. So what we do is we set all our clinics up that we actually have access to those local GP services.
Excellent. Yes, that's really interesting to know, because I think that can be a barrier initially, can't it, for the practice, and that can cause quite a stumbling block as to whether you can actually offer that person an eye test, or it's hard to understand where you can get that kind of information from sometimes, isn't it? So you can actually process these things. So it's interesting to know that. But speaking about barriers for the patient, so there are a lot of barriers as to why a patient in a homeless situation wouldn't be able to access normal optometric care in a primary care setting. So what kind of barriers and what kind of problems do they face?
Many problems, definitely. I mean, it's the sort of inability to sort of deal with sort of bureaucracy and getting sort of like services organised. The biggest barrier actually probably is cost. I mean, people, I think opticians, practices will have a very sort of retail appearance to them, so people think it's going to cost them a lot of money to go in. So I think that's one of the biggest barriers. But also there is the psychological barrier that people actually often just don't feel comfortable going into a practice. So also if someone books an appointment, because their lifestyles tend to be more chaotic, It's actually the difficulty with keeping that appointment. But often we find that sort of the majority of the homeless people we see actually do have access to mobile phones. So basically sort of cheap pay-as-you-go phones are sort of very accessible. So often people do have a mobile phone, so we can always sort of text them in advance or give them a call if they've forgotten to come into their appointments. And often for a homeless person, having a mobile is actually one of the only ways that they can actually keep in contact with family and friends, because if they don't have an address, having a mobile phone sort of it'll be a sort of like an essential sort of contact to the outside world.
Yeah, definitely. It's amazing how everyone has mobile phones, isn't it, really, even people in that situation. So you have to make the best use of them. But the mental health aspect, and like you say, just that anxiety of putting yourself in a position where you're going to be the odd one out, aren't you, really? You're going to be sat in that waiting room full of people who are probably going to, you know, look at you funny. They're going to be almost suspicious of you, you know, which is the wrong way to feel, but it's a natural response, I'd imagine, for most people. But it is a difficult barrier just to put yourself in that position initially, isn't it, really?
Yes, definitely. I think the psychological element has a sort of a big part to play. I mean, say, for example, in sort of one of our recent projects, just over about 18 months ago, we ran a project with a domiciliary service through a couple of homeless organisations in East London, in the Tower Hamlets borough. And basically, to have a domiciliary NHS eye examination, there has to be a barrier for someone to come into high street practice. Now, the majority of the time that service is actually used for elderly people in a care home or housebound at home. But basically for homeless people, that's a very different situation. For them, there has to be sort of a mental anxiety or a block that actually stops them from going into high street practice. So, I mean, also from our sort of things on the domiciliary contract, the other barrier was that you have to submit 3 weeks in advance the list of the people that you're going to see on that day of testing. Now, unfortunately, that may work for a care home or if someone's housebound, but with homeless population is often, even on the same day, you can go in, sit yourself down, set up your kit in the morning, and you can get a queue of people waiting. But often they might be distracted by the food service or the laundry, or they might even just forget why they came in. And you booking someone 3 weeks in advance, there's a very high rate of people not showing for those appointments. So actually I think it was something sort of really low, like only about 7% of the people we tested in that pilot were actually eligible for GOS services. So basically 93% of those were funded privately through the charity.
Okay, yeah. And do you find that there's quite a big interest once you're in a position to offer these services? Do you find that people coming to the shelters are quite keen to have an eye test?
It's a mixture. I mean, often having an eye test isn't a high priority for homeless people because they do have more urgent needs going on, like food, laundry, showering, things like that. So we do have quite a high percentage of prescriptions coming through, so probably higher than you would in the general population. And that might be because people are actually seeking us out because they're actually they've broken or lost or had their glasses stolen. I mean, we've had prescriptions as high as, I think it was sort of like something like about -20 and +17, and regularly getting 3, 6 sills, things like that, because people are desperate to sort of get replacement glasses because they actually sort of need them to survive.
Yeah, definitely. I mean, if you imagine just surviving day to day normally, if you've got a -6 still, or you've got, you know, a -20 or anything like that, it's difficult, isn't it? Even, you know, you get your -1s that come into practice and complain how they can't see anything.
Yeah.
So really to have that kind of refractive error and to be in that position could be, you know, extremely daunting, quite dangerous to a degree as well.
Absolutely. I mean, you're in a very high risk environment. And if you can imagine yourself, I mean, say if you've just got a straightforward prescription like -3, -4, if you lost those glasses or they were broken, how would you actually survive sort of seeing things down the street, keeping yourself safe? So certainly for someone who is experiencing homelessness, it's essential to their sort of daily survival. Absolutely.
Yeah, definitely. So what other kind of eye problems do you come across? and what kind of risk factors can sort of, determine what kind of ocular problems you'll see?
Certainly, people, unfortunately, because of their sort of chaotic lifestyle, they often have quite poor nutrition, so their general health actually seems to be sort of quite poor. Hygiene levels can be difficult, so we often get a lot of people with sort of anterior eye problems, sort of like blepharitis, dry eye and things like that. Also, smoking rates are 3 times higher among the homeless population, so potentially sort of retinal sort of problems, toxicity of smoking. So because people tend to have those chaotic lives and it's a more exposed life, potentially outdoors more, sort of the more common things we tend to find tend to be things like cataract and, as I was saying, blepharitis. Also a higher rate of retinal problems, so say if someone is assaulted, so sort of traumatic sort of retinal problems, muscular balance problems because of trauma as well. So it does tend to be that they have sort of slightly higher sort of risk levels of those sort of types of problems. Also, if someone has got general health problems, so say for example they are diabetic or they have high blood pressure and they are experiencing homelessness, often their control of those general health problems is sort of a lot sort of worse. So there is the potential for sight-threatening problems from that. So sort of hemorrhaging from diabetes, high blood pressure, because they're not able to control them sufficiently.
How does it affect with regards to referrals as well? So if you're seeing these kind of problems in practice, and in any normal situation you'd make a referral, do referrals get processed in the same way? Do they tend to follow up on the referrals? Is there a it's often that even patients in general practice can be reluctant to go to the referral appointments, and you often have to chase them up and make sure they've actually gone. So is it a similar situation? Do you find that you're referring and people aren't going to have these problems dealt with?
At the moment, I would say we don't know, but I'd say that there is a higher probability that you refer someone from our clinics and actually that referral never gets actioned. We have got a project ongoing at the moment, which is a referral sort of follow-up pathway, and we've got a group of optometrists, a lot of the optometrists actually colleagues from Moorfields, who are sort of basically sort of taking on the follow-up of those referrals. So say for example, if we are referring someone to the sort of the eye hospital, what the optometrist can do is actually to support that patient through that process. We've also linked with another homeless charity called Groundswell, and they're basically a peer-led service, and what they have is people who used to be homeless and they are aware of the sort of the difficulties that people are experiencing, and what they do is they actually support people through that service. So this is all sort of a very recent thing, so we don't have the findings of the first sort of part of that project, but we are hoping firstly to actually be able to sort of monitor how many referrals are actually happening, but also the ones that do slip through the net is actually to follow up with those people and enable them to get the sort of the secondary health care that they need. Yeah, definitely.
Yeah, definitely. And like you say, initially there's barriers to attending that initial appointment in the first place, and then going on to a second appointment, you're going to have all those same barriers again, which makes it difficult. And again, that whole anxiety, that whole mental health aspect as well, in putting yourself in that position and going into that kind of environment. So what other kind of problems can affect the homeless people in terms of ocular conditions and things like that, and just generally coming into practice and things like that?
I mean, the majority of the problems, I mean, the highest percentage of problems is actually refractive error. I mean, we find that I think it's 35% of the people that we see coming into our clinics could effectively be registered blind with or visually impaired without having their visual correction. So the most straightforward sort of problem is actually refractive error. So if you think of in the UK, we do still have people who are effectively visually impaired because they don't have their sort of correct spectacle prescription. So going from there, then it's a mixture of things. I was saying, sort of like the cataract, because people live a very outdoors lifestyle with very poor nutrition, that tends to affect. So they've got higher UV exposure, being outside more, higher rates of cataract. Glaucoma, potentially, we're not quite sure at the moment on that one, but certainly much higher rates, as I was saying, of sort of like ocular motor problems, just basically from being assaulted, or it could be that they have a higher rate of problems with sort of their sort of visual balance. So yeah, there's a whole mixture of problems on there.
So do you find that there's a higher incidence of things like substance abuse, alcoholism, drug abuse, that kind of thing? And how does that impact on your ocular health?
Certainly the rates of substance abuse are a lot higher, and that can be a combination of reasons. It could either be that was one of the sort of initial problems that actually caused the sort of situation of homelessness in the start. I mean, often for most people it's actually a sort of a real combination of issues that actually spirals people down to that sort of situation that they're in. And actually one of the most common problems with sort of issues of homelessness is actually relationship breakup. So I think it was 41% of the population. I think some Mungos did a big study with people using their services, and they found that as I was saying, 41%, it was relationship breakup. So if you have a couple in a flat or a house, if the relationship breaks up, then one of them has to move out. If there's children involved, then commonly the woman will tend to stay in the accommodation with the children, and the man has to move out. I mean, I did even hear sort of a few years ago about a dispensing optician who had split up with his wife, and he moved out and unfortunately couldn't afford 2 sets of accommodation. And it was only about sort of 3 or 4 weeks down the line, when he'd been sleeping in his car using the local supermarket to sort of wash, that he actually confided in his colleagues about the situation that he was in. And often the difficulty is that people don't know what to do, who to turn to, and that sort of situation spirals down. And often substances can actually be a coping mechanism. So if you have someone that's actually got to that sort of desperate stage in their life, that sort of things are they are losing control of things, is that it can actually be a coping mechanism, whether that be sort of drugs or alcohol. So certainly there are higher rates among the homeless population. So it can either be that it was one of the initial causes, or it can actually be something that they have sort of slipped into because of their circumstances. And so yes, smoking, alcohol, they all have their sort of impact on the eye as well as the rest of the body, sort of depending on the toxic levels they're taking in. So alcohol, drugs, smoking, all can have a toxic effect on the eye.
Definitely, yeah. How does that affect your test process?
Well, the majority of centres that we are in, actually, the people coming into us are not under the influence of their substance. The only time that will be different is that when we run services like the Crisis Christmas, so each year we have the Christmas service, which runs from the 23rd to the 29th of December. And there we see probably about sort of 300 people in a week. There is one particular centre within their group of places, and they often have about 10 different centres across London, is they'll have one called a wet centre. And that wet centre is basically someone who is sort of in a situation that they are addicted to a substance, and whether that be alcohol or drugs. And actually they're in the stage that they need to be sort of rehabilitated and in rehab to wean off those substances, but they can't do that immediately. So we will actually go in and test within those centres. And often in those situations, you actually just literally have to test depending on the the approach that the patient comes to you. So it might be that someone won't say anything to you, can't say anything to you, and you're basically just sort of managing how you can. So also pupil size can be something that's sort of quite different. I mean, if you've got someone that's on alcohol, often their pupil is sort of very dilated, so you get a very good retinal view, whereas some drugs may constrict the pupil and therefore may restrict your view quite considerably. So I think basically the same as if you're dealing with people with different abilities in practice, you would do the same thing for people who are homeless, is that, as I'm saying, literally the majority of the time that we're seeing people is that you are seeing people who are not under the influence of their substance. But if you are, then you are working in that situation out of choice, and you just sort of manage the situation as you are. I was saying it could be that someone has a high prescription but they have broken their glasses or they've lost them, and it's just it might be sometimes you do a quick quick ophthalmoscopy, and you're just doing the best to provide the service sort of almost in an emergency way to sort of tide someone through that sort of really difficult time until they can be rehabilitated through rehab, and then maybe you get a more accurate refraction result at the end.
Yeah. Do you tend to find that being in that test room environment for a homeless person, do you feel that can be a trigger of anxiety and fear, being in that kind of one-on-one situation with a stranger?
Yeah, certainly. I mean, any member of the population knows that actually going in for an eye examination can be something that brings anxiety. I mean, I've certainly been in situations where I've had 7 people faint in my career, so it's basically you do get really anxious. Not that I make them scared, but the majority of those are around contact lens fitting. And it's basically that you have to sort of you'll have to sort of like change your routine around the way that that person feels. Sometimes it might be that you have to leave the door open, or they bring a friend in, or sort of like sometimes you even need to test people in stages. So it might be that you only get a small part of the test done and you're building a relationship with that person, so that you just literally have to manage the situation as it is. I mean, also another difficulty sometimes is actually language barrier. I mean, basically you may get someone who doesn't speak particularly good English, and that might be either sort of someone who is living here, resident here, or someone who's a refugee. So we have sort of had people sort of who are, say, for example, we had once where we had a family come over from Syria, and they literally just had to leave, and they left all their belongings there, and the 2 children both wore glasses, but of course had no glasses, and it was going to take them about a month to get all the registration for sort of NHS services here. So we carried out an eye examination and got some glasses just to sort of tide them over. So you do have lots of different sort of situations, and with those you can either use a friend or family to translate, or if you've got your own mobile phone, the translation apps are quite fantastic. You can literally put in a question, translate it, get the patient. It's a little bit slower to do it that way, but you can get around it. So yeah, absolutely.
Definitely. So what kind of advice would you give to ophthalmologists and DOs in your general high street practice if a homeless person came in asking for an eye test? What would be your kind of advice?
First thing is actually not to assume that they're not eligible for NHS services, because it might be that actually they are eligible for a GOS eye examination. So it's actually just sort of talk to that person. I think it's just being sort of really open with them, finding out sort of what their circumstances are, if they are on any benefits. If they are on benefits, then you can, under normal circumstances, carry out a GOS eye examination. One of the other difficulties we find is often people sort of fall between the cracks if they've lost or broken their glasses. So currently for adults, they are only entitled to a GOS voucher every 2 years. So if someone breaks or loses their glasses, then unfortunately they have to wait till that sort of interval before they can get another voucher. So it is difficult. So if someone is eligible for GOS services, then please do use those GOS services. If they don't have a fixed address, if they've got a care of address, if they're a sofa surfer, which basically means they have no fixed abode, but they might be sleeping on the couch of sort of family or friends or something like that, use that care of address. If they are someone who is sleeping on the street, then you can give the address of a day centre or hostel or GP service or somewhere where they go. You can use that. If they're not eligible for GOS, then that's a very different sort of thing. We have some practices who have actually set up a local service with their sort of local homeless services, and what they will do is maybe once a month they will go in and deliver an eye examination. We've had other practices who will open their practice one afternoon a month, and then the homeless people from the local area can actually come in, access the services free, and they are effectively paying for the eye examination themselves. They are providing that free of charge. And some of those have set up contacts with local labs and frame manufacturers that they've actually provided the glasses and the lenses free for that service. So it's a mixture of things. I mean, from our side of things, we have sort of a whole range of options that we can support practices through setting up something with their local homeless services. There was another organisation up in Nottingham where 4 practices got together, and actually between the 4 of them they were running a service once a month, and they actually now have still kept that going for about the last few years, which is fantastic. So so there are options out there. From our side of things, in the long term, we would really love to get sort of regulations changed. So, I mean, the sort of best thing we could get is actually that homelessness was opened up as being an eligibility for GOS services in the first place, because all the people you're seeing have low income. So if we could get GOS, equally if we could get a repair voucher for people experiencing homelessness, as you could do for someone who has epilepsy or medical conditions and things like that, that would be fantastic as well. So we are working with NHS England. Unfortunately, things keep coming along to get in between those discussions, Brexit, coronavirus, things like that. So we will keep those sort of dialogues open and see what we can do in the sort of long term. But in the short term, unfortunately, if GOS isn't available, it's just charity is the other option. So, yeah.
Yeah, definitely. But it's a worthwhile thing to do, isn't it? Definitely. And although obviously any practice needs to make money and any practice needs to be remunerated for their services, but if you can spare one afternoon a month to provide these kind of services, then it's a hugely beneficial thing for the community. So interesting, you mentioned obviously the current COVID situation. So how is that impacting what you do and the homeless kind of population in general?
Actually, for what we do at the moment, we have closed all our clinics. We actually probably closed at the sort of earlier stage than everyone else. 2 clinics shut really early, one of them because pretty much all our volunteers in that clinic were actually over about 70, because we have a lot of people who have retired and are coming back to the optical service to sort of give back. So we shut that purely for the health of those volunteers. We also had another clinic close sort of pretty much straight away, purely because the homeless centre provided a lot of accommodation, and from their side of things they wanted to reduce the risk of the virus being brought in, so they shut down all external services so that they could minimise the sort of people that were coming into contact with the homeless people that were residents in their centre. And then within a very short period of time we shut down all our services. Basically, I mean, with homeless people, because they sort of are very poor general health conditions, they are very vulnerable to picking up any sort of health problems around. I mean, generally in sort of a normal sort of non-coronavirus time, homeless people are more likely to access A&E services because they don't access primary health care. So they often end up with health conditions that actually get to a very sort of critical stage because they haven't been accessing normal sort of primary health care. So, and this situation just makes that thing much worse, is that sort of they are very vulnerable, low immune systems, very prone to picking up viruses, and for them to be sort of more severely affected, they've often got a lot of other comorbidities happening. Also, the other side of things is actually the physical distancing. I mean, because when you look at sort of like hostels and sort of day centres and things like that, because people are in very close sort of physical distance from each other, that physical distancing sort of can't really happen. So a lot of those services have shut down. So thankfully, I think it was on the 23rd of March, the COVID homeless policy came out. And actually what they have been doing since then is actually bringing homeless people into sort of hotels and things like that, so that they can actually self-isolate. And what they've been doing is screening and separating people who potentially do have the coronavirus, as opposed to those that don't, to actually help sort of reduce that infection spread. But certainly it's a very difficult time. So from our side of things as a charity, what we're doing is we're working behind the scenes. We had been working on a series of projects to sort of get a more computerized, streamlined system for our sort of volunteers coming online, for volunteer training and things like that. So we've been working behind the scenes, sort of getting that set up. We're also looking at sort of how we go forward, other clinics that we potentially are looking for, sort of other roles we're going to be creating in the future. We're going to have a new a new clinic lead role, which is going to be sort of advertised as soon as we come out the other side of this. Also, last year we had a project called the Homeless Voices Project, and we linked together with a company who have experts by experience. So basically the people who used to be homeless, and they actually now have sort of stabilised their situation, and they are now housed, working. And what we did is, with the experts by experience, we did a series of focus groups and 170, I think, questionnaires. And what we're looking at is how people sort of experience eye care and general health care. So we're writing up the sort of the findings of that study from there. So we're linking up with some of the statisticians at Moorfields, and we're looking at the results of that. So we're working behind the scenes on sort of basically going forward is getting our systems in place, so as soon as we can get up and running again, we will be out there delivering the service where it's needed. We can provide replacement spectacles, so if someone does lose or break their glasses and we've tested them before, or they've got a copy of their current prescription, we can supply emergency glasses. So we're doing just a basic essential care, but other than that, no testing or anything at all at the moment.
Yeah, definitely. It's interesting, like say, how I suppose when you're in the frontline position and you're actively doing that kind of work and you're seeing those patients on day to day, there's also a lot of background work that needs to be done. And especially, like you say, in terms of research, in terms of statistics and understanding the patterns, who's actually come to see you, there's so much that needs to be recorded and analysed. So I suppose it's difficult for you in that position to do that. So having a team and having that kind of support behind you to get that information is really critical going forward, isn't it? Because you want to be able to adapt and provide an even better service in the future. So this is important, definitely. So what are your big plans going ahead then? Because obviously at the moment with a lot of charities are struggling at the moment, aren't they? Because people aren't able to get out and fundraise and stuff like that. So what kind of things have you been getting up to, and what kind of plans have you got for future fundraising?
Definitely still fundraising. We had the 2.6 challenge the weekend just gone, and I think there were at least 3 of us doing sort of mammoth challenges. Basically this was because the London Marathon didn't actually happen. So we had Alison Gordon basically did 26 games of table tennis within the day. We had a lovely lady, Ella Oldfield, who rowed or canoed something like 26 miles up a river, which I'm amazed about. I've got no upper body strength. And then myself, I did a big cycle challenge. I don't know if anyone else is into indoor cycling, but there's an indoor platform called Zwift, which has a lot of the sort of traditional sort of like Tour de France stuff, and their big climb is something called Alpe d'Huez, which is the same virtual equivalent of a mountain called Alpe d'Huez in the French Alps. And basically my husband devised the challenge, which was a really big challenge, which is 2,600 meters of climbing on Alpe d'Huez. And it took me 4 hours and 43 minutes to do that. Wow. And so I was shattered on Sunday. So so we are still fundraising behind the scenes. We've got a sort of like a reading challenge going at the moment. So if anyone would like to log on to our website, they're sort of very welcome. If they've got the spare time and they're reading some sort of lovely books, then please let us know what books you're reading. Set a challenge for your family and friends and things like that, so get the children involved. But we're definitely sort of fundraising sort of behind the scenes constantly, and as I was saying, working on our systems to sort of keep us going. But certainly we do have big ambitions. Currently we think we see probably only about sort of like maybe sort of 9-10% of the homeless population in the UK, and we want to increase that quite significantly. So we want to increase the number of clinics we have. So if anyone's interested in volunteering, they can certainly sign up, go through our application process at the moment. So we are still open for all of that, and get all the registration process sorted so that when we are up and running, definitely they can come and sort of volunteer and visit our clinics. We'd like to, I mean, in the long term, ideally like to have a bus which is sort of fully equipped with sort of a consulting room, dispensing area, so that we could move that around, take our services to homeless people. So yeah, we've got big ambitions. So yes, we're definitely sort of planning for the future.
Brilliant, excellent. Obviously we've got a big plan. Hopefully eyecare Glasgow is going to go ahead. Hopefully COVID will be all done and dusted by January. But we're happy to have Vision Care for Homeless People as our chosen charity of the event. So when we do our little awards ceremony on the night and our drinks reception, we'll be having a little fundraiser, a little charity auction, a few prizes, a few little raffles and things like that. Maybe a bit of a casino. So we'll hope to raise a few quid for you as well, because it's a fantastic charity. I mean, I first heard about it at Opticians. Just wandering around, bumped into one of your colleagues there, and it sort of surprised me that there was a dedicated charity for this, because it's something that never really occurred to me. Obviously, you always expect to see homeless charities, but I did never think of the link between optics and homeless people. But looking into it, like I say, it's a fantastic charity, and it's really, really rewarding what you do, and it's making a real difference in people's lives. So you've done a fantastic job, Elaine. I think everyone that knows you feels that a lot of pride that the fact that you set this up. So it's fantastic, and you should be recognised for all your efforts. So it's amazing. Well done.
It's great fun. I mean, basically all our volunteers absolutely love coming into the clinics every day, and it literally is. I mean, just the sort of smiles on the faces of the people that you see coming through. We have people that come back to us. We had a chap in our Shepherd's Bush clinic who was collecting his glasses, and he said that he'd been devastated that he couldn't sort of find work because he couldn't read a computer screen. His eyes were really painful and sore. So he collected his glasses, went off to his next interview at the job centre, and then returned a few weeks later to say that he had a full-time job and was working as a sort of kitchen porter. So it literally is changing lives. So it is quite fantastic. I mean, everybody knows how precious sight is, and so to your physical and mental well-being, sort of being able to see well and how you can perform in life. But if you imagine that you didn't have that, as well as all the other sort of barriers that homeless people have to face, is that we just need to get that service out to them. But as I'm saying, I really can't emphasize enough about how rewarding it is volunteering in the clinics, because you meet some really interesting people from all backgrounds of life. We've met people who were accountants, airline pilots, ex-services, but it could be anyone from any walk of life. So it's just the circumstances that have led them to that. So yeah, it's a really great thing to do. Love it.
Yeah, definitely. Like I say, it can happen to anyone, can't it? So it's something that everyone should be aware of, and everyone should try and do their best to help anyone in that situation. It's just such a shame that we have to have charities for this kind of thing, and it's not 100%. Something that can just be supported through normal GOS services and things like that. So hopefully that's something that can change in the future. But but hopefully there's less of a need for what you do in the future as well. So that would be a big step forward as well, definitely. So before we finish up, Elaine, is there anyone that you want to say thank you to out there? Any companies or any suppliers that have supported you in the process, and in terms of supplying the glasses or anything like that?
We have a huge sort of list of people that I would love to sort of focus on. I mean, the support and the love that we get in the optical industry is actually quite fantastic. Basically, each one of our 8 clinics is actually supported by a different lab for the glazing. So sort of remembering some of them off the top of my head, we have Essilor, Shamir, Kentoptic, Horizon Optical, Caledonian Optical. I apologise for the ones that I haven't remembered. Frames, we get the frames donated by Specsavers. Equipment, some of the equipment manufacturers, absolutely amazing. Again, off the top of my head, the main ones: Topcon. Who else? Basically my brain's going. Zeiss, Birmingham Optical, Keeler. I mean, you name it, everybody is absolutely fantastic. And the support from practices as well with their volunteers. Some practices will sort of like give their staff sort of like maybe half a day or a day off, that they can actually come in and work in the practice. People doing sponsored events for us, so companies like Performance Finance, they do sort of like their sort of like corporate fundraising. They've done some amazing events for us, including sort of like a lot of their team doing a huge skydive, and the one that I was really most impressed with was a fire walk. So they've raised thousands for us. But sort of like the optical industry is absolutely fantastic. It's a brilliant community that comes together, and you can see at the moment how it's pulling together for the coronavirus times. And yeah, it is absolutely superb, and I'm just really proud to be a part of it. So yeah, thank you all. So I apologise if I haven't mentioned.
There's one off the top of my head I could think of, is Out of the Box Optics, who did the Optiversa challenge. That was really cool. So yeah, we couldn't actually make it to the event. We donated a couple of tickets to eyecare for when the winners qualify. But yeah, that looked like a great show, that did. So I think they raised quite a lot of money as well. No, that's been going a few years now, and the number of teams is increasing. Also, CET side of things, so the ICT, and so basically the conference up in Glasgow, really fantastic. So yeah, Peter Charlesworth and his team, absolutely superb. Also the professional bodies, I mean, like Photo have given us a lot of support over the years with our sort of like policy side of things, and actually supporting our sort of negotiation and work with NHS England. So yeah, absolutely. So, and actually the team of trustees and the volunteers, I mean, certainly we couldn't get anywhere without those, and our staff as well. So it's a brilliant team, and as I say, I'm just really proud of it and just love being a part of it. So yeah. So what we can do is, if there's anyone that you feel you've missed off the list, if you email them to me, and I'll pop a list on the screen. I'll put everyone in the comments as well, so everyone can get a shout out then as well, so we don't miss anyone.
Brilliant.
So that's it for today, Elaine. I mean, it's been really interesting chatting to you. Like I say, doing amazing work, so keep up the good work. And then we'll definitely be seeing you in January.
Yes, thank you very much. Brilliant conference. I loved the conference this year. I thought for all members of the practice, whether it be sort of optometrists, dispensers, clinical assistants, I think it's a fantastic programme. So loved being out there, and it's a pleasure to go back again next year, definitely.
Yeah, definitely. So yeah, we'll definitely be there. eyecare 2021 in January up in Glasgow. So yeah, look forward to seeing you there. So yes, thanks for everyone for listening. Hope you all enjoyed it. We're going to be recording another episode tomorrow, which is going to be all about COVID-19 and how it's affecting the optical industry and the challenges that we're going to face going forward and post-COVID, how everything's going to change. That's going to be a really interesting one too. So yeah, so thanks everyone. We'll see you all soon.
Thank you very much, everyone.
Thank you.
Bye.